All right, we'll get started. First of all, I just want to thank everybody here and in the virtual world for coming, and more importantly, for taking care of my patients. For a few of you, probably for 20 years now. Most of you are a little younger, but you guys have all done a great job taking care of our patients, and we've had actually very good results here at Salem with our thoracic surgical program. And it's largely due to you guys, so I appreciate it. So just a chance for me to say thank you. Chest tubes are one thing that to some extent, it's like many times it's like watching my grandmother program the VCR. They're mysterious because they're not used very often. A lot of people don't have much experience with them, and they're actually pretty simple once someone explains them to you, but a lot of times people just never get much experience with chest tubes. So I was just going to go over some of the basics of chest tubes, and Lisa's going to help me demonstrate a few things with PleurX catheters as well. And please feel free to stop me and ask questions. If anybody has to get up and go and tend to clinical matters, please just jump up and go. If anybody wants to get up and eat a piece of pizza, please just go ahead and do that. It's not going to distract me or anything. So please feel free to just make yourself comfortable. I just wanted to start out with a little introduction to, let me see how to do that. There we go. I got to click that twice. A little bit about the mechanics of breathing. When we breathe, the lungs actually don't have any muscles in them. The reason we breathe is that our diaphragm contracts, and when it contracts, it goes from being dome-shaped to flat, and that creates more space in the chest. And that additional space in the chest has to be filled with something, and that is filled with air coming in our nose and mouth and filling our lungs. And then when we relax, our chest goes to a smaller conformation, and we passively exhale. Breathing only works if the muscles for breathing are working, if the lungs themselves are normal, if the airway is not obstructed, and most importantly for our talk, if the pleural space is normal. So what is the pleural space? That's our next question, because understanding the pleural space is kind of the basis for understanding the chest tube. So the pleural space is the space or the potential space that lies between the outside of the lung and the inside of the rib cage. And normally there's nothing in that space. Normally our lung is touching the inside of our rib cage, and there may be a little bit of fluid in the pleural space that lets the lung slide against the rib cage as you breathe. But in general, the lungs normally fill the entire chest cavity, and there's not any fluid or air of any significance within the pleural space. I got to do that this way. So what should not be in the pleural space? Pretty much anything, since the pleural space is supposed to not have anything in it's usually a problem. So if you have excess fluid in the pleural space, that's called a pleural effusion. If it's blood, that's called a hemothorax. And if there's air in the pleural space, that's called a pneumothorax. And anytime you got something in the pleural space, you have something taking up space in the chest at the expense of the volume of the lung. So you have less working lung the more fluid you have in the pleural space, or the more air you have in the pleural space around the lung. And this is where a chest tube comes in handy to try and drain this air or fluid. So over here on the left, we have a chest x-ray of someone who has a right pneumothorax. So if you see this little line, that's the edge of the lung. That normally should be all the way out to the chest wall, but it isn't. So that's a big air pocket around the outside of the lung. And then there's also a little flat line here, which means there's some fluid in the chest as well. And this might be typical of someone who broke a rib and the rib poked the lung, and they get a little bit of bleeding into the chest, and they get a little air leaking out of the lung into the space around the lung, and you have a hemopneumothorax or a hydropneumothorax, depending whether that's blood or fluid. And then we'll slip a chest tube into that space and drain out the fluid and hopefully suck out the air. And if there's any ongoing air leaking from the inside of the lung to the outside of the lung getting trapped in the pleural space, the chest tube will evacuate that air as well. And hopefully that'll keep the lung inflated, and eventually the injury will heal up and the tube can come out and the patient can go home. Just a cartoon showing the same thing. This is a hemothorax. Here's a lung that's being squished by blood around the chest. So this is kind of a double whammy. The person's lost blood. So this is blood not in the circulatory system. So that's as good as blood on the floor. And not only is the blood not circulating, it's actually squishing the lung. So you have a respiratory embarrassment as well as the bleeding. So that's not a good situation to be in. And here we see again a chest tube lying in the pleural space to evacuate this blood. And oftentimes, if this blood's from trauma, just the simple act of getting the lung up will cause the injury to tamponade. And I would say about 80% of chest trauma can be managed simply with a chest tube and really doesn't require any advanced surgical care. Feel free to come on in. Oh, Dr. Ott. Do you guys know Harold Ott? He's one of the other MGH thoracic surgeons that work. He's slightly younger and better looking, but not nearly as qualified.
Everything I know from Jim. So.
Yay.
All right. So for a chest tube to work properly, first of all, it's got to be in the right space, and that's kind of on me. If it's not in the right space, that's a problem. If it's fallen out of the patient and it's on the floor, it's by definition not in the right space, so that's kind of a problem too. And the tube has to be not obstructed, either not obstructed internally with clot or with tissue, but also just as simply as it can't be kinked or pinched under a bed rail or something like that. So the tube has to be patent all the way from the patient all the way down to the suction container. Connections have to be airtight, and then the tube has to be attached to a system that will allow air and fluid to drain, but it also has to be a system that will not allow air or fluid to re-enter or enter the chest. So the system we use are these PleurX. This is Atrium's brand. PleurX, actually, I think Decnatel's brand name. This is an Atrium Oasis, and this acts like a one-way valve to let any air or fluid in the chest drain out, and then when the patient breathes in, which would create a little bit of negative pressure in the pleural space, this has a one-way valve mechanism in it that prevents them from sucking air back into their pleural space, because the whole goal is to empty the pleural space. So this acts as a one-way valve. And the system also will not only work as a passive one-way gravity drain, it will also, you can also put it on suction to actually help suck what's in the pleural space out. And we usually use, if we put a chest tube on suction, minus 20 centimeters of water suction. And what that really means is centimeters of water, like millimeters of mercury, is a measurement of pressure. And most people don't have any feel for how much that is. I mean, if I told you someone weighed 80 pounds, you've got a picture in your head of what 80 pounds is. But if I told you, I'm applying minus 20 centimeters of water suction, everybody's like, how much is that? Well, it's actually really simple. That's why I went to Taco Bell today. So this straw is about 20 centimeters in length. And the amount of suction it takes me to suck this fluid up to my mouth is minus 20 centimeters of water suction. It's enough suction to bring water 20 centimeters up a straw. Okay? And a millimeter of mercury and a centimeter of water are roughly the same thing. Okay, so that's not much suction at all. It's really much less suction than we use with the tonsil tip sucker in the mouth or anything like that. It's very minimal suction. And you'll see a lot of surgeons like chest tubes on suction. You'll see a lot of surgeons just like them on water seal, which just means it's working as a one-way passive gravity drain. There's very little difference between those two states. So all the obsessing we do about it probably doesn't make a heap of difference, would be my guess. But that just gives you a little better idea of what we mean when we measure suction in those funny units. Another phenomenon that I want to talk about is Tidaling, but I think I better just show you first about setting up the PleurX, and then I can demonstrate some stuff on this. This is one we used in a demonstration a week or two ago. We'll lose my Christmas tree. Another Christmas tree. Yeah, I'll put that on. So this is the end that's going to go to the patient. There's a cap that would be on this when you open up fresh in the package. You want to keep this end sterile. So just this connector is really the only thing that needs to be sterile unless you're opening the whole unit onto a sterile field. And then in the back here is a little container that had some water in it. And we already did this once, but basically you just twist the top off of it and you put it in this hole. This is the only hole up here on Atrium's model, so you can't go wrong. You squeeze all the water out, and that will go down into this, what we call a water seal chamber. There's some blue dye in there that'll turn the clear water blue so you can see it. And that's basically all there is to setting up a chest tube. We can set the amount of suction that the patient perceives using this dial right here. And when I push the dial from the side, you can see the little orange thing point to a different number. It comes out of the box preset at -20. And then the only other thing you have to know is that if you want to apply suction to the pleural space or to the chest tube, you have to apply suction right here from the wall. And the amount of suction that the wall is set at doesn't really matter. What the patient perceives is what this dial is set at. So you just need enough suction from the wall to make this little orange bellows here puff out. And any excess suction from the wall, if you've cranked the wall up really high, just gets bled off by the system and the patient won't perceive it. So you just need enough suction to puff up the bellows and keep it puffed up at all phases of the respiratory cycle. And that's enough suction. And technically that would be just a little bit over -20 if this is set for -20, but you don't have to adjust the wall suction perfectly. You just have to have it attached and sucking in general. Did I miss anything on that? You set these up more than I do. Okay, do you want to, yeah, we'll see the bellows here.
Under the water.
All right. All right, fire it up there. Yeah, that'll, we'll go up a little more.
Sorry. No, that's fine.
That's about what we get. That's good.
The travel one.
It's okay. It's not bad. You see the orange thing puff up, and then if I disconnect it, it drops down. You just need enough to make the orange thing puff up. Okay. Now I put my finger over this, and this would be, if you look right here, you see nothing bubbling. So there's no air leak in this system. But if the patient's lung had a hole in it and air was leaking from the inside of the lung to the pleural space, and that air was finding its way to a chest tube, what you would start to see is you'd start to see some bubbling here. You see the bubbling there? And that's an air leak. So that means somewhere there's air that's getting into the patient's pleural space that's being evacuated by this system. It could be a true air leak, meaning there's an injury in the lung that's actually leaking air and the chest tube is scavenging that air and it's bubbling out, you know, like through this one-way valve like it should. Or it could just mean you have a loose connection. And if it's really bubbling like crazy, sometimes that's a disconnect. Sometimes it's a disconnect under a big pile of tape that you wouldn't necessarily understand is disconnected unless you unraveled all the tape and took a good look at it. And I'll tell you a little bit about a couple tricks about how to tape a tube. So we're okay on making the bellows puff up, enough suction to make the bellows puff up, and then observing down here for an air leak. So there's a big air leak, and there the air leak went away when I covered the end of the tube. So if a tube has no leak in it, it may be a perfect tube, meaning it's in the pleural space, the lung doesn't have a hole in it, there's suction on the tube, the lung is up, everything's perfect, or it could be a kinks tube, okay? So those are the two states that this can be in when you don't see an air leak. The other thing you'll sometimes see, you can shut that off. The other thing you sometimes will see is what's called Tidaling. And Tidaling is where this fluid oscillates up and down as the patient breathes, and I'll try to do this. Now, there was actually no air leak there because no bubbles went across, but you can see the fluid Tidaling in the water seal chamber. What that means is that the tube is in an airspace in the chest. It's not good, it's not bad, it just is what it is, but it means your tube is in an airspace in the chest. And as you breathe in and out, that airspace becomes under a little more and a little less pressure, and the fluid oscillates. The nice thing about a tube that tidals is you know that the tube is patent, it's not kinked. The difficulty, again, when a tube doesn't tidal is it's either perfect or it's obstructed. So that's just something you have to deal with. All right, let me move on here. I think we talked about titling.
Dr. Allan, excuse me. So
Yes,
if the ball got stuck on the top, what would you do?
I'm sorry, what were you asking?
If the ball gets stuck on the top?
I actually don't worry about it, to be honest with you.
All right.
There's this little ball here. In the event of extreme negativity, will suck up to 20, and then it just sticks there, so that you can't suck the water out of the system. Essentially, most patients won't reach that unless they are really having exaggerated respiratory efforts or a cough. And usually you don't need to do anything. The ball usually will drop down and free itself. There is a little button on these things where you can let some air in the system to reduce excess negativity. But I personally don't even believe in the concept of excess negativity. The negativity would be generated by whatever the patient's doing. So I don't think it can be excess, because we're not made to be able to do that. So I don't even worry about the ball. It just adds to the confusion. All right, let's see where we are here. We talked about that. We get the titling. All right, dressing a chest tube. I want to show you one quick way that I like to dress a chest tube. This actually is a little more complicated than I usually use. Just trying to get it on the screen here.
4x4. Yeah, do you have any 4x4s or something similar?
Oh, those are good. So let's just pretend that the chest tube's coming out this guy's chest here. All right, so that's his body. Pretend like this is what we're trying to dress. Ignore that piece of tape. I usually just take a 4x4 and fold it and stick it under the chest tube. And I just take another one and stick it on top. And I just take some big tape and tape it. That's all I do. It's easy to undress. I don't bother cutting notches in sponges. Then when you try to undress it, you're like picking the sponge out from the tape. And I think that's probably the easiest thing to do. The pad underneath it helps prevent a pressure sore, and the pad on top just covers the hole. And, you know, I'll usually go pretty big with the tape. Can't really have too much tape. If the hospital gets hit with a nuclear bomb, you want them to find your patient's body with the chest tube still in it. So you can never have too much tape. And then I'll pinch up a little bit and flag it. Again, if you tape straight to the skin, people get a pressure sore under the tape. And then I would probably do one more good piece of tape here and flag it a little bit. Really make sure it's stuck. But so I don't think you have to get more elaborate than that. We don't usually use Vaseline gauze or anything. I think that's all you really need for a chest tube. And then in terms of taping the connection here, I'll just show you what I usually do for the connection. One second. This tape here. As I mentioned, sometimes you can see a disconnect, or you can have a disconnect and not be able to see it. So when we put these tubes in, usually I'll give this the best push that I can give it. And then I like to take 1-inch tape and make a nice long piece of it and just tape it lengthwise. Because now I've got about 2 or 3 inches of tape on each structure, and it's going to separate this way. If I put the tape this way, I only really have about a 1/2 inch of tape in the direction it's separating. And I'll usually come once around the ends here, just to keep the ends from coming up. You guys can help yourself to some pizza here.
Yeah, it sounds like that.
Please go ahead. The nice thing there, though, is you can see the connection. So you won't have a disconnect that you won't recognize. If you just do big rounds of tape on here, you can get a disconnect under the pile of tape. And we've actually had a couple of patients that stayed 3 or 4 days longer than they needed to, because we thought that they had a true air leak, when in fact they just had a bad connection. And we missed it, and everybody else missed it too. So that's kind of how I've been taping things. But just realize if you get one that's completely taped, you could have a disconnect under the tape and not realize it. And you could always give it a good push and make sure it's together. Questions on that? All right.
I like that taping.
Yeah, I just try to keep it simple. I like this cloth tape. The other thing I'll just mention about tape is don't stretch tape and then put it on someone's skin. If you stretch tape and do that, they'll get tape blisters around the edges because it creates a lateral shear force on the skin. The other way you can get tape blisters is by putting a really good piece of tape on and then the patient swells. They'll get blisters too. So if you have a patient that's swelling, you should untape and retape everything occasionally. But I really avoid the stretch kind of dressing. Just put it on, but this tape sticks pretty well. The microfoam tends to come up on a lot of people that are oily, so I don't use it usually. I kind of like this tape, but I suppose anything works if you keep if you're attentive. Well, I had a couple more slides, and then Lisa and I want to talk a little bit about PleurX catheters. Just some troubleshooting. All right, there's a kink. This is a pigtail catheter, so that's a little different than a surgical chest tube. It's a little smaller, and then it connects to this little flimsy piece of tubing, and there's a kink right there. So that's not going to drain anything, and that's going to require some sort of a retaping or maybe a popsicle stick to splint it or something like that. I really don't like little tiny drains. I think you should go big or go home, because this is a life-saving item, and to have something that flimsy and small just doesn't seem like a good idea to me. I've seen that. That's usually someone spinning around when they're on the telephone, or getting tangled in their Johnny and rotating around their IV pole 3 times, and they forget that they're doing that to their tube. I see that a lot. There's another person who's spun around a couple of times. Let's see. All right, so that's a complete disconnect there. I don't know if you can see it, but underneath this clear tape, there's basically an air gap there. This Christmas tree ends there, and then the new thing starts there. So that's not even, they're not even touching each other, but you wouldn't on a quick look necessarily recognize that. What else do we have here? This is someone who lowered the bed onto the PleurX. They'll crack, or someone kicked it over, and then you don't have a sealed system. Yeah, I think that's everything. All right. PleurX catheters.
Can I just one thing? 'Cause
Yeah.
I know a lot of people, wonder if we cracked the PleurX,
Mhm.
then we're getting a new one to change it, to disconnect,
So
just that it's, just kind of. talk
if
about
this
it.
if this is cracked, what you can do is just open up a new one, set up a new one of these, and then this will separate right here. So what I would do, and this is going to be in the patient, right? Put it in there. So that's in the patient. What I would do is I would just fold that over in my hand and separate it there, keep that sterile, and then just snap the new one in and unfold it. You can use clamps if you like.
For this.
Don't they come with, like this, don't they come with a loose clamp on?
Yeah, I throw this out. I personally, when I put a tube in the OR, because I had a situation where a guy had a chest tube and his fidgety grandson came to visit him, and he clamped him. He was sitting here doing this, and he clamped him without even thinking, which on someone with an active air leak could cause a tension pneumothorax in a clinical emergency. So I always think this is an accident waiting to happen. So I just get rid of these, but not everybody does. So I just fold it over my hand. That's as good as anything else, I think. But you can use this. Just don't forget to take it off. And don't let the kids play with it. Don't play with granddad's chest tube. All right, we were going to talk about PleurX drains. So if you have a PleurX catheter there, we'll sometimes put these into patients that have chronic pleural effusions. Let's see. These are relatively clean. I'll send that your way. They were only an infected patient for a short while. No, they're okay. So the felt cuff here will be placed right under the skin, and this part will be in the chest, and then this part will be outside of them. So it's very much like like Hickman catheter or something, but it's just the thing that goes into the pleural space. And the felt cuff kind of creates a barrier between outside and inside, because over time tissue will grow into it and kind of block the track so that germs can't go up and down the track. And then this is a kind of a specialty Lurlock with a valve in it. So even though there's no cap on this at the moment, there is a closed valve in here. So this catheter is at the moment closed. This also has a pinch clamp on it too. But patients that have chronic pleural effusions, oftentimes we'll put this in and we'll send them home with it. Visiting nurse will come and attach an evacuated bottle to it, maybe every other day or every third day. And whatever fluids accumulated in the pleural space will get drained out to the bottle. And then they'll recap it and they'll put a dressing on it. And we'll show you how to do that. So it's just a small chest tube that you can go home with. It's not suitable for managing an ongoing air leak because there's no one-way valve to allow that air to exit. It's really only okay to manage a chronic pleural effusion where you're accumulating a little bit of fluid and you want to drain it off every day to try to keep the lung mostly inflated. If you leave someone with a chronic pleural effusion for any length of time, the lung being squished by the effusion around it will stay in the squished position even if you draw the fluid off eventually. It gets like a rind on it and won't re-expand, or some people call that a trapped lung. So this helps deal with that situation in an outpatient way. Once in a blue moon, a patient will come in with one of these in and we'll want to attach it to active drainage. And there's a little kit here that has the parts in you need to do it.
Or for us too, they all in the recovery room, they'll come out sometimes with
This
attached,
setup.
and then you have to disconnect it.
So this thing has this end, which has a little piece that defeats the valve here. So this little straw goes into the valve and pushes the valve open and it clicks into place. And then this end here has a Lurlock that can go on this half Christmas tree, half Lurlock thing. And then you got your scissors. And then we would lop off the Christmas tree that comes with the chest tube, like so, and hook that to that. And that's how to turn a PleurX into an active chest tube. Okay.
Where would I find one of those if I needed one? In the delivery room or down here?
I think we have them right in the closet there. And the OR certainly has them. And I have one or two in my office I keep for an emergency when people call me and say they can't find one.
In another pack, because I went to find one for today and they couldn't find just that. So
Just this, okay.
I don't know if they're in like
We'll figure that one out. That's a good question. The one person who sometimes needs this in a hurry is the emergency room, because sometimes they'll have someone come in with a PleurX and they'll want to convert that to active drainage, either because their effusion got so big and they're in respiratory distress, or that there's some other problem going on, like an infection that they need to drain, or even once in a while people can develop a pneumothorax with a PleurX in. So we'll figure out where to find these, but usually the residents have been able to find them. I haven't had much trouble here with people finding them. So if we send a patient out of the OR like this, I'll let Lisa take over from here, kind of how she would convert this to a form for a person to go home with, and how that dressing change is done and everything. It's a little bit of a complex process, but it's not that bad. You want to have at it?
Sure. So initially, before I became familiar with the PleurX catheters, I was like, I didn't want to disconnect this and people home, because you think it's a two-way, air can come rushing in, but it is not. It's a one-way valve. So all we literally do is twist it and pull it out. When they come out of the OR, they'll come out with like one of these caps in like a sterile container, and the cap just goes like right on. You just put it on and you twist it and you feel it click.
But just to keep it clean,
Yep.
It's already airtight without the cap.
Right, so that's literally all we have to do. And then they go home, we dress it, and then they go home, and they're usually sent home with like a pack of two PleurX catheters for the VNA, and that's all set up through case management. So for us, like literally, if they come out and they're with us for a few hours, a lot of times they're admitted, and so this happens the next day. But for the recovery room, it's literally just you twist it, pull it, and then add this cap on, just like that. And with those ones that we sent around, if you see this caps on the end, you can see how if you take the cap off and just kind of put it on and twist it, you kind of feel it click. And so that's, I mean, it's pretty simple.
Yeah, feel free to play with it.
Yeah, I mean, I think so. So that's that. But if, say, you have someone coming in with a PleurX from home. I know this because my mother had one place here 4 years ago. And when she was admitted, and we learned how to do it at home and all that kind of stuff, it was really pretty simple. But when she was admitted to Davenport 5, really people weren't familiar with it and how to drain it, how to, we have the kits here, but it's not you. I don't think you have a huge population that, come in with them. So I thought it would be good just to talk, show how you actually do it with, open up the kit and dress it and drain it and, right?
What do you mean? What kind of
No, I have all my stuff over here. So they do come in with two sizes. These are a liter, and then these are 500 cc's. Like people with ascites and have like abdominal, like the PleurX can be in an abdominal area. They usually use these to drain. Initially, she did though drain 750 and then 500 from. So we had the big balls to start with, but anyway, for the most part, I think most people don't drain a whole lot more than 500, and they do say not to drain more than a liter at a time anyway. So these are just what they look like, out of the package.
They're disposable, one-time use.
Use my other 4x4, but
Oh, I can get it back for you.
oh, that's okay. And I was gonna put in the other. I was gonna put one in here just to.
Go ahead and set that up. And I will-
Okay,
I
so
will
like you
get
said,
the
this cup here will be inside. You should see that from the outside, and typically it's sutured initially. And then like my mother, it just kind of like will never come out, so it's kind of be in there forever. And it's just like I think I don't even know how you'll get it out if you have to.
Everything can come out.
So anyway, just like that. So that's all on the inside. And what you'll see if they come in and you're going to change the dressing and you want to drain, this little cut foam piece here goes under the skin, just like Jim was talking about earlier, so that you don't have any skin breakdown. This is folded, over like that, and then you'll have a couple 4x4s here, and there'll be a tegaderm,
Big tegaderm.
big tegaderm covering the whole thing. And there's usually you put like a couple of 4x4s. Because they'll have this on, and if you don't cover it well, they can feel the cap and stuff that sticks out.
The foam thing keeps them from
Yeah.
getting a pressure sore. Like if they're a side sleeper, at least that thing with the cap in is not digging directly into their skin. And then this gauze on top prevents the tegaderm from sticking all over the catheter and you having to spend an hour picking the catheter out of the tegaderm.
Right. And it's hard. I mean, it's hard to do because so a person cannot really do this on their own because where it's placed, unless it's really anterior. I know most people it's like lateral, and it's sort of like, and it's almost a two-person job. Like I'll have her, once I do this, I usually have her put her hand there, and then I get the tegaderm, and cover it up.
Yeah, you need at least 3 hands for 3 or 4
Yeah.
hand job.
So
That's all in the kit.
yeah, so I'm going to open the kit now and show you. So they'll come in with the tegaderm, and now we're going to do let's just move all this stuff out of the way, and I'm going to open up the kit there. Even she was admitted to the emergency room, and I literally had to run up here to get the kit. They didn't have it down there. The ER nurse didn't know really how to use this, or so it's kind of, I get it. People don't use it a lot. And there was an ICU nurse that came down, when we were on D5, so I'd have to come in every day to do it. But not hard to do it if you haven't seen it before. All right, so this is all in the kit, right? It's 500 bottle. And this is going to be a sterile There's also a really good website. It's PleurX.com. And they have a video and it's really helpful. And that's what people, you know, when they go home and they do these on their own, and families learn that way. So it's just a Tidaling. I'm going to put that over to the side. All right, so this is covered. So like, you know, my mother, people, I think they sit up in a chair, whatever. It's just like they're sitting at the kitchen table. So they're sort of usually inclined a little bit. This one's not. So yeah, so it's just, this is going to be a sterile field. And then what I'm going to do is I'm going to take this off. So and this is covered already right now. So, you know, I'm not touching this with non-sterile hands, but I am going to pull this off. And you just sort of lay it onto the sterile field, right? And then I'm going to have another pair of gloves, and I'll take off her, you know, the dressing, wash my hands, and then I'm going to put on the sterile gloves. Always huge and bulky. There'll always be a clip in here, you know, in case, I think you'd only use it if for some reason this got sheared off, you know, or something. But this, like I say, is, and this is, yeah, that's okay. But anyway, we never needed to use that. You take, there's 3 alcohol wipes, and I put all the stuff that, you know, sort of I'm not using over to one corner. So I will take the cap off this. I wouldn't have just left this down without a cap on it, but there'll be a sterile cap on. I'm going to take that cap off and I'm going to put it over so I don't reuse the wrong one. And you just take an alcohol wipe and you don't put anything inside, but you just kind of wipe the end like that. And then you're going to take this sterile tip and it just literally goes right in and you feel it click. Okay, so now it's connected. So now I can let go of it. Over here, this is a suction bottle, but there's a little plastic piece that keeps it from, you know, like in delivery, you know, applying suction so it doesn't work anymore. You just remove that. Always clamp it first, because as soon as you push this down, suction starts, and I will tell you it causes them a lot of pain because it sucks like against tissue. And every single time it causes a little pain, but they get used to it. And then, so if you just open it slowly, then it's actually a little bit better. So I'm going to just push this down.
So that spikes the bottle.
And this will create the suction. And, you know, if we were attached to a real person, you slowly open it and you can start seeing like, there's just a noise. Anyway, foam and, you know, the liquid and whatever. I'd say it takes anywhere from 5 to 10 minutes for it to drain. It's actually pretty quick. Like a light yellow color, it's, you know, to amber foam. And so you know, do it until like there's like air bubbles, sort of, you sort of can tell when it's done draining.
You'll usually get a little soreness too whenever the lung gets suction hickied right up against the catheter in the chest wall.
And yeah, so usually, you know, that's how you kind of know. So then you just clamp it off. All right, and then all you do is you pull it out when you're done. It's just literally just in and out. It doesn't, you have to twist it or anything. And then this is the sterile cap that I'm going to actually place back on. And you put it on and just hear that click. So it's a fresh one, so it's actually working. So just, that's all you do. It's all drained. Like I say, you know, it's a one-way valve, so you don't have to worry about air rushing in while it's disconnected. You don't want to keep it open for long, but you know, once you just put it on. And then it's just the dressing. So again, I'm going to take this foam that's underneath. All right, and just like twist it like that. And then here, the part I miss is I usually take an alcohol wipe and I'll just go around her skin with it before I put the dressing on. But then I just put this on. And then this is where it becomes like a two-person job. Like I'll usually have her put her hand there so I can. And I will say that this.
You don't like the TV screen method, do you?
So what I don't like about this one is it covers a lot of skin, the one that comes with the pack. And after like a week, she was all red. You know, people who are like sensitive to Tegaderm and sticky tape. So what I do is I use release, because then you can just put.
This one gets a little unwieldy when you.
Well, I mean, you can use it, but what
It starts to misbehave very quickly. So sometimes
so
using
this
this,
is in the
particularly if you're alone.
package, and you can certainly use this. But if you have patients who their skin is getting really red, if they they're in the hospital for a few days, I will put like, I'll cover this all up, and I'll put like just on the edge. She'll be holding this for me, so it's actually a little bit easier. So I'll put just one on the edge there. I'll put one on the other edge here, and then one just underneath, but I overlap them so that just around, there's only like an inch around her. Huh? Yeah, exactly. It's kind of
This is hard to do unless you have two hands.
Yeah.
Trying to apply this one-handed, it usually ends up in the big sticky ball.
So yeah,
Like like a Band-Aid.
but like I said, it's hard to. But if you get one on, then you can get the other ones on. But I'd say that's the gist of it. I use 3 of these, and I just think it's like better on their skin, because you can see, like, you can go all around it, and you only have like an inch on either side.
You guys have any questions on PleurX's or chest tubes or anything else you want to go over?
I just have a question about the chest tube
Mhm.
regarding patient selection, and how is it that you choose a straight versus a curved and that kind of thing?
Most of the chest tubes we put in surgically are straight tubes, and usually if we're expecting a lot of drainage or have done a large operation, my personal preference is to put in 2 straight tubes, one that lies anteriorly and one that lies posteriorly. If we have a real bloody field, if it's for trauma, if it's for infection, I might even put 3 tubes in, and usually then one of the 3 tubes would be a basilar tube, which is like a right angle tube that would get stabbed in or placed in over the diaphragm, and that's why the angle is useful. So it'd be an angled tube over the diaphragm and 2 straights. Some people will use a single straight surgical type chest tube, and they'll put in something that's more like a softer drain as a second tube. It's all surgeon preference, really. And I think the fact that all these different ways coexist probably means there's not a huge amount of difference between them, and it comes down to more preference. I'm a big believer, though, if you've got a problem, to treat the problem aggressively once right. So if I've got someone with a bloody pleural effusion, I want a nice big tube, and I don't want some little tube that's going to get clogged up that then they're going to have to go down to IR, and they're going to put another little tube in, and then 3 days later someone's calling me to do a VATS on something that, had I drained it properly the first time, we wouldn't even be going to the OR. So I tend to put big tubes into people, but that may be a little bit old-fashioned. Some people try to minimize the stuff. The problem is you sometimes get burned when you try to do less rather than more at the beginning. So, but it's a preference thing. I'll usually put 2 of those straight type tubes in most patients that have had a lobectomy. If it's a shallow wedge resection, I'll probably just put 1 tube and try to have it laying near the area of the wedge resection of the lung, because that's the area that's likely going to leak.
Thank you.
I don't know if that fully answers it. I don't know that there's a great answer, because it probably doesn't make a huge amount of difference.
Good answer.
You could ask 10 different people and they'll give you 10 different reasons for what they do. It probably doesn't matter that much. Other questions at all?
I actually have one question.
Yeah.
So when we're transferring somebody and like their chest tubes on the wall suction, you said really like the suction's so minimal that it really doesn't make a difference. So when we're like transferring, say, from like ICU to D5, would it be fine to just leave them off the suction for the transfer? Or do you recommend putting them on the portable suction?
I'll tell you where the difference is. I would say 99% of the time it doesn't matter. You will find people that will feel extremely strongly about this, and I think much of that is because they don't actually understand how little difference there is between no suction and -20, because they haven't been to Taco Bell and had a soda lately and thought about it. The one thing I would say, if you have a patient with a true air leak, this water seal chamber is 2 centimeters deep. So they actually have to build up positive 2 centimeters of water pressure before they bubble. So with a chest tube in place attached to this system, you can have a slight amount of positive pressure in the chest before that air vents across this, water seal. When they're on -20 of suction, that you'll never have positivity in the chest. It'll always be evacuated. On some people, positive 2 centimeters of pressure in the chest is enough to cause subcutaneous emphysema. The air will find another pad. It's not under pressure enough to blow it across this water seal, but it might blow out into their fat and they might get sub-Q air. So I think if a patient does have a true air leak that's being managed with suction, it's probably best to keep them on suction. If it was just a patient who had a pleural effusion drain and there's no air leak, there's no need for transferring them on suction. And I don't think actually suction really makes much of a difference on the pleural effusion. The fluid, just like air, will find the path of least resistance, which is going to be the chest tube, and come out. And every time you breathe in and out, it's kind of acting like a bellows to help squeeze the fluid out.
I'm wondering if there's some nursing policy around transferring with low suction.
Our policy is whatever the order says. So if the provider has ordered suction, the policy says they travel with suction.
When we go into Epic for a chest tube order, it asks that specifically, may patient travel off suction.
Okay.
And so I don't know that we're forced to fill it out. I always fill it out. I don't think it's a forced category. And again, I don't think you're going to make a huge difference, good or bad, for 99% of the patients. That's not to say someone won't go mental whenever they don't see it that way, but I'm just telling you today, it's not worth going mental over.
Okay.
Other questions?